Okay, welcome everybody. This is chapter 23 dealing with the digestive system, and we're going to discuss the components of the digestive system as well as what each of these components do as food makes its pathway from the mouth to the anus. We'll discuss where the waste products go, where the nutrients go, and the various treatments that occur along the pathway. We have to understand that we need the macronutrients in our diet in order to not only obtain energy, which is in the chemical bonds of the macronutrients of the food we eat, but we also require it for building blocks in order to assemble the rest of the body's tissues and cells. So we have to ingest food, and then we have to both mechanically and chemically digest it. So mechanical digestion is the physical breakup of what we eat. So that's chewing, churning, swallowing, mixing, okay, all of that, which does not change the chemical composition of the food in any way. The chemical digestion is the physical breaking down of chemical bonds in those macronutrients, and most of that is carried out by proteins that we call enzymes. Okay, what happens next is that we absorb the nutrients, and then we excrete the waste products that we don't need. The study of this system is called gastroenterology, and let's learn a little bit more about the digestive system.
Part 3, the digestive system.
Uncle Frank, you are a nutty, crazy man.
None of these people are my family. In fact, they don't know me, and I've invaded their picnic. But they've been gracious enough to let me be around them and their food while we explain the intricacies of the digestive system.
We've all heard of the digestive system. We know its job is to break down food and absorb nutrients.
Once the digestive system breaks down this food, it can be absorbed by the body for nourishment.
In this part of the tape, you'll learn all about the organs involved in digestion. But that's not all. I will actually demonstrate digestion by eating. This entire watermelon, 3/4 of this apple pie, and a whole Cornish hen. So you can check back with me every now and again as you're learning about the organs of the digestive system.
The digestive system can be broken down into two sections. First, there's the alimentary canal, or gastrointestinal tract. This can be called the GI tract for short. Then there's the digestive accessory organs. We'll look at the gastrointestinal tract first.
Section A, the gastrointestinal tract.
The gastrointestinal, or GI tract, is an open-ended tube that food passes through. This food gets digested and absorbed along the way. The GI tract is divided into 6 regions: the oral cavity, the pharynx, the esophagus, the stomach, the small intestine, and the large intestine. The act of digestion begins in the oral cavity, otherwise known as the mouth.
The oral cavity, or mouth, is the place where food gets chewed up by the teeth. The technical term for chewing is mastication. For all normal people, it's the first place that food enters the body. Abnormal people may put food elsewhere, but they will not be discussed in this tape.
When food gets masticated and mixed with saliva in the oral cavity, it's rolled into a soft, mushy ball by the tongue. This food ball is called a bolus. The tongue, teeth, and salivary glands are all digestive accessory organs associated with the oral cavity, and they're all responsible for bolus formation.
American League Bolus Ball. It's fantastic.
Good evening, I'm Mark Talbot, and this is Walt Filton.
And you're watching the American League Bolus Ball Championship. It's a championship for champions. That's why it's a championship.
Yes, today Elias Walker, Bolus Ball champion, will send a bolus that was once 3 slices of swirl rye bread rocketing down his gastrointestinal tract.
Exciting stuff, Marv. Walker learned to chew in the inner city and then went pro at age 17. Now, let's check in with Elias Walker, ready to turn bread into bolus.
Yes!
It looks as though Walker is exercising his tongue, an important muscle that helps form the bolus. Walker's tongue, like every tongue, is a mucus-covered skeletal muscle that shapes and softens food by working with the teeth. Adults have 32 permanent teeth.
The teeth are responsible for mastication, or simply put, chewing. Right, Marv?
I'm still stuck on mucus-covered skeletal muscle. Yuck! Let's check in now again with Bolus Ball champion, Elias Walker.
It looks as though Walker has begun chewing the bread, his tongue forming it into a bolus with the help of moisture from the salivary glands.
That's right, Marv. Right now, his salivary glands are thinking about one thing, salivating. We'll be right back.
The salivary glands are very important in the early stages of digestion. The salivary glands secrete saliva via small ducts to moisten food.
These glands secrete saliva filled with enzymes and other substances. The saliva is responsible for the initial digestion of carbohydrates.
After the saliva, teeth, and tongue form a moist bolus in the mouth, we swallow the bolus. Another name for swallowing is deglutition.
Welcome back. Elias Walker has just swallowed the bolus.
That's right, Walt. But now the real challenge begins as the bolus passes into the next part of the gastrointestinal tract, the pharynx or throat. Let's get a close-up of Walker's pharynx.
Well, that's boring and reveals nothing. Let's now turn to an artist's rendition of Walker's pharynx. That also tells us nothing. Let's look at a real diagram. Yes! As you can see, the pharynx is connected to the oral cavity and uses its muscles to propel food downward towards the esophagus. Inside the pharynx, bacteria contained in the bolus can be destroyed by the tonsils. Tonsils are also tissues in the lymphatic system.
That's great digestive action, just like back in the 70s when I used to digest.
It sure is, Walt, but you and I both know that the greatest Bolus Ball challenge is yet to come.
That's right. After the bolus hits the pharynx, it passes into the esophagus or food tube. So Walker is really in the zone now.
Yes.
The esophagus is the tube that transports the bolus directly to the stomach.
The esophagus drops the bolus through the gastroesophageal sphincter into the stomach. Basically, it's just a passageway to the stomach.
Welcome back. The bolus is now in Walker's stomach, and the stomach is a pretty exciting place, isn't it?
Oh, yes. It's full of acidic juices that are juice-like. Walker is on fire.
Yes!
When the bolus hits the stomach, watch out. It's goodbye bolus, hello chyme. This is the final inning of Bolus Ball. We'll be right back.
You see, when the bolus reaches the stomach, it stores the bolus for a while.
Then, the stomach begins a chemical breakdown of proteins inside the food. This breakdown turns the bolus into chyme. Chyme is a disgusting, creamy paste of semi-digested food. It's in the stomach where protein digestion begins.
Well, that's the end of the bolus and the end of the first part of digestion.
Nowhere to go but down at this point.
Now, let's check back with Bolus Ball champion Elias Walker, still digesting.
Yes. It looks as though the bolus has hit Walker's stomach. Now we play the waiting game. He'll sit there like a slug for a few hours while it digests.
Oh, hello again. My stomach is full of watermelon and game bird. How are you? Oh, don't answer that. Instead, concentrate on the next part of digestion that occurs in the intestines.
The first part of the intestine is the small intestine.
After the stomach turns the bolus into chyme, that chyme passes into the small intestine through a muscular structure called the pyloric sphincter.
The small intestine is the longest part of the gastrointestinal tract. It's responsible for chemical digestion and the absorption of carbohydrates, proteins, and lipids or fats. It also absorbs 7 liters of the 9 liters of water it encounters in a day. You don't really have to worry about the details of the process of absorbing water. Save that for physiology.
The small intestine can be broken up into 3 regions: the duodenum, the jejunum, and the ileum.
The duodenum is about 10 inches long and begins at the pyloric sphincter. It's the first section of the small intestine. The duodenum receives a bunch of important digestive juices, like bile and enzymes, from digestive accessory organs like the liver, the gallbladder, and the pancreas. But don't worry about these organs just yet, because they'll be coming up again.
The jejunum is the next section of the small intestines. It's about 8 feet long. That's pretty long. If it were human and had basketball skills, it could play for the Clippers.
The ileum is the final section of the small intestine. The ileum terminates at a structure known as the ileocecal valve. The ileocecal valve is like a little partition that separates the small intestine from the large intestine. The ileocecal valve opens up to let food into the large intestine and keeps food from backtracking into the small intestine. So, it kind of works like the valves in the heart. All total, the ileum is 12 feet long. If it had basketball skills, it would be a freakishly scary NBA player, taller than the net.
The next major part of the digestive system, and my favorite part, is the large intestine. Oh, God, I love it. I love it. I love it.
The large intestine forms the end or terminal end of the gastrointestinal tract. The large intestine is actually only 5 feet long, but it's wider than the small intestine. That's why we call it large. Still, it's not large enough to become an NBA player, nor is it short enough to become a lovable child star, like Canadian Phil Steuben.
The large intestine absorbs 90% of the remaining water from indigestible food. That's about 2 liters of water. When too much water is absorbed by the large intestines, we get constipated. When too little is absorbed, we get diarrhea. Either way, the semi-solid indigestible food residue left over is called feces. In any event, the large intestine has 3 sections: the cecum, the colon, and the rectum.
The first section of the large intestine is known as the cecum. The cecum is continuous with the ileum of the small intestine. It's separated from the small intestine by the ileocecal valve.
There is an appendage on the medial surface of the cecum called the appendix. The appendix contains lymphatic tissue nicknamed MALT. MALT stands for mucosa-associated lymph tissue. This tissue helps eliminate bacteria.
The appendix has a twisted shape. Because of this, fecal matter full of bacteria builds up and becomes trapped there. When this happens, the appendix becomes infected and inflamed, and it's hello appendicitis.
The cecum leads into the colon, which forms a frame around the small intestine.
The colon forms a rectangular-like frame around the small intestines. Under normal circumstances, the large intestine would make a pretty disgusting frame. But in this case, it works just fine. The side of this frame, located on the right side of the abdominal cavity, extending out of the cecum, is called the ascending colon. The top, horizontal part of the frame is called the transverse colon. The part located on the left side of the abdominal cavity is called the descending colon. And finally, the bottom part of the frame that leads into the rectum is called the sigmoid colon, a name for Dr. Sigmund Freud.
Last section in both the large intestines and the gastrointestinal tract is the rectum.
The end of the rectum is called the anal canal. The anal canal is equipped with muscular sphincters that control the defecation process.
And we're nearing the end of the gastrointestinal tract as we approach the anus.
Actually, the rectum springs directly out of the sigmoid colon and leads to the anal opening, or anus. The very end of the GI tract is in the anus.
That's the end of the gastrointestinal tract. But before we move on to talk about the accessory organs, why don't you digest this?
And now, a blatantly untrue anatomical tidbit.
Did you know that in Cuba, the gastrointestinal tract is actually called the gastrointestinal tract? And that's a blatant untruth.
Section B, the accessory organs.
There are 6 accessory organs involved in the digestive process. Each one of them serves a different purpose. The first 3 we've already talked about. They are the teeth, the tongue, and the salivary glands. The teeth and most of the tongue are found in the oral cavity.
The major salivary glands are called extrinsic salivary glands. They're found in, or just outside of, the oral cavity. They are connected to the oral cavity by ducts.
The other 3 organs are the liver, the gallbladder, and the pancreas. These organs are all associated with the duodenum, the first section of the small intestines.
The liver is the largest gland in the body. It's a red, 4-lobed gland that weighs about 3 pounds in the average adult. The bulk of the liver is to the right of the body's midline. It's almost completely surrounded by the rib cage. The liver also produces bile, a gooey yellow-green liquid that's full of salt, pigments, and lipids. Bile helps the body break down fat.
The liver also enjoys removing nutrients from the blood, storing vitamins, detoxifying waste, and taking long walks on the beach.
The gallbladder is another accessory digestive organ.
The gallbladder is a green, 4-inch long muscular sac located on the lower right surface of the liver. Bile made in the liver travels into the gallbladder via the bile duct. So the gallbladder is kind of like a bile storage center.
It's the Fort Knox of the body.
It stores excess bile, then it concentrates bile by absorbing water out of it. Finally, it delivers bile to the duodenum of the small intestines. It does this by contracting and discharging bile into the cystic duct. Then the cystic duct connects with the bile duct to form the common bile duct, which eventually leads to the duodenum of the small intestines by way of the hepatopancreatic duct.
And lastly, there's the pancreas, another accessory digestive organ. The pancreas cooks up most of the enzymes needed for digestion. Actually, the pancreas produces both digestive enzymes and hormones. We'll tell you more about hormones a little later on when we talk about the endocrine system.
The pancreas is a yellowish tadpole-shaped gland. Its cells produce pancreatic juice, which contains tons of digestive enzymes. Pancreatic juice is delivered to the duodenum by way of the hepatopancreatic duct. Pancreatic juice is also the third most popular beverage in the United States. For crazy people.
Drink it up, drink it's pancreatic. Juice it up, juice it's pancreatic. Juice it's pancreatic. Juice. Juicerific!
Hello, I'm sluggish. And now, just as you're done learning about the digestive system, I'm done eating more watermelon and poultry than any man alive. I've gorged myself, and you've learned about the gastrointestinal tract and the accessory organs. Now, you can go on to learn about the urinary system.
One of the things that we have to note about the digestive tract as we go from the mouth to the anus is that in large segments of the tract, there are distinct tissue layers that have specific tasks in order to complete the job of mechanical and chemical digestion. Okay? Those layers are the mucosa, the submucosa, the muscularis externa, and the serosa or adventitia. So the mucosa's job is to line the tract and to create surface area for absorption to take place. In order for us to get the nutrients out of the tract and into the blood, we need a lot of surface area, and that's what this provides for us. There are numerous glands in this layer of tissue that produce a lubricating mucus that protects the tract from physical trauma and also from certain enzymatic activity that could break the tract down. This is especially important, for instance, in the stomach, which is part of the tract. We also see enzymes that are attached to the surface of the mucosa that complete the job of chemical digestion so that we can absorb the tiniest components of the big macronutrients, the proteins, the lipids, and the carbohydrates all need to be chemically broken down into something that can be absorbed into the blood, and that's what these enzymes finish up doing. The lipids are broken down initially by lipases, and they're eventually going to be passed into the lymphatic system, which then will empty into the blood supply where the thoracic duct meets the left subclavian vein. And then the breakdown products of proteins, amino acids, and the breakdown products of complex carbohydrates, which are simple sugars, will be absorbed into the blood supply and via the hepatic portal vein make their way to the liver. Okay? And then the liver will essentially store that material for later use as fat or as glycogen before passing the blood that flows through it to the rest of the body through the hepatic vein. The muscularis mucosa is sort of a dividing line between the mucosa and the submucosa, and the muscularis mucosa's job is to allow the mucosa to undulate, and that helps a little bit with mixing, but mostly allows the contents of the tube to come into contact with these enzymes that line the border. And then beneath that is the submucosa, which is connective tissue, as well as glands that produce mucus. Okay? And there's also a substantial number of immune cells in the submucosa that guard against any pathogen that we ingest, making it into the bloodstream. So those include B lymphocytes, T lymphocytes, all the granulocytes, the macrophages. Okay? In between the muscularis mucosa and the submucosa is a nerve net called the enteric plexus. And we also see that nerve net between the submucosa and the muscularis externa, and between the externa and the adventitia. So the idea behind this nerve net is simply to provide for nerve impulses that let the smooth muscle squeeze the material through the pipe so that it can get to its final destination. Okay? So the digestive system, interestingly enough, would function even if no nerve leads from the peripheral nervous system via the central nervous system talk to it, which is kind of nice. It means that it basically operates on autopilot. The adventitia or serosa is simply to latch the tube in place so it doesn't twist, buckle, or kink and impede the passage of food. The serosa is a membrane that produces a lubricating fluid so that as there's movement taking place in the tract, it doesn't produce friction, in addition to the fact that it latches the tract to the surrounding structures. Adventitia is found primarily in the upper third of the esophagus, where it simply serves to attach that organ to the surrounding material. We should also note that flowing through the serosa is nerves and blood vessels and lymphatics that serve the organ. Okay. The process of propulsion through the digestive system is called peristalsis, and these are waves of smooth muscle contraction that are going to push the food ultimately from the esophagus all the way to the anus. And this is primarily through the action of the muscularis externa. Note that in most of the pipe, the muscularis externa forms an inner circular and outer longitudinal layer. However, in the stomach, there's an additional oblique layer that aids in churning. The propulsion also produces mixing as well as moving the material from one part of the pipe to the next, and that's going to aid with chemical digestion as well by facilitating contact with the walls and also by breaking down the chunks of macronutrient physically into smaller pieces. Okay? The reason this is possible is because smooth muscle has gap junctions in it that allow the rapid movement of electrical signals from cell to cell to produce a uniform contraction in those sheets. Okay? Now, one of the places that we need to focus on is really the beginning of the whole trip, which is the oral cavity. The oral cavity is your mouth, right? The lips border it on the outside, and they're attached to the gums, which are the gingiva, by the labial frenula. The tongue is attached to the floor of the oral cavity by the lingual frenulum, and it contains papillae on its dorsal side for frictional grab, and those papillae also have on their lateral margins taste buds so that we can have a sense of flavor. The gums or the gingiva are going to surround the components of the maxilla and the mandible that contain the teeth, which come in different shapes for different jobs. The incisors for chopping, the canines for slashing, and the molars and the premolars for grinding. Okay. We note that on the top of the oral cavity, the hard palate is formed by the palatine process of the maxilla and the palatine bone, and of course is coated with mucous membrane, which is non-keratinized stratified squamous epithelia, and that actually runs all the way back from the hard palate to the soft palate, which terminates in the uvula in the very back, into the throat, specifically the oropharynx and the laryngopharynx, the oropharynx being behind the mouth and the laryngopharynx being behind the larynx. Emptying into the oral cavity are salivary glands, two parotids in front of each ear, a sublingual under the tongue and a submandibular under the lower jaw, produce a mix of serous and mucus secretions that not only begin the process of chemical digestion through salivary amylase and lingual lipase, but also produce antimicrobial components that cut down on bacterial growth in the oral cavity. They allow the food to be compressed into a moist ball called a bolus, and they lubricate it. And the mucus lubricates the entire passageway. Okay? In addition to that, we know that the dentition in the oral cavity is that of an omnivore, right? The molars are flat for grinding, the canines are sharp for slashing, and the incisors are kind of shaped like a chisel, and they're for chopping. And that is essentially the dentition for eating really anything, fruits, vegetables, meat. The omnivore mouth is well equipped to deal with all of that. The teeth that come into the oral cavity, you get a set of deciduous teeth, which are your baby teeth or your milk teeth, and then a set of permanent teeth. You got 32 permanent and 20 deciduous teeth. As the deciduous teeth fall out, the permanent teeth come in behind them. The third molars, which are in the very back of the upper and lower jaw, usually don't come in until your early 20s. Frequently they come in an oblique fashion, and that can crimp the teeth so that they don't line up properly for your bite, and that creates a condition called malocclusion, where ridges on teeth in the top jaw can hit ridges on teeth in the bottom jaw, and the enamel can shatter, and that can cause infection. We should also note that bacteria that live in the oral cavity can form little communities on the enamel that coats the teeth, that's called plaque, and produce acids that can erode the enamel away. And if that were to happen, then the soft dentin beneath the enamel is much easier for the bacteria to essentially break down and decay, and eventually they could get to the pulp cavity and the root canal, where blood vessels and nerves are located, and that might have to result in extraction of the teeth. If we don't floss and brush, one of the things that happens is that the plaque builds up and the gums can get inflamed, and that's called gingivitis, right? If your gums bleed when they floss, that means that you're probably not taking good care of your teeth. And if we continue not to treat that, and you continue with poor dental hygiene, the gums may actually begin to retract or recede, and that exposes the neck of the tooth, which has no enamel on it, and then it's a relatively quick trip for bacteria to go up and under the enamel crown and get into the either into the pulp cavity or the root canal. And often that results in you having to have all your teeth extracted, at which point you get your third set of teeth, which we know better as your dentures. Okay, so you always want to make sure and floss and brush every day, just like your dentist told you to. Okay. Occasionally, the salivary glands can get stones lodged in their ducts. This is a condition called sialoophysis, causing extreme pain when you eat or you salivate. We can deal with this via lithotripsy or surgery. Okay. We should also note that viral infection, childhood disease known as mumps, can hit the salivary glands, producing swelling and pain. One of the reasons that we prefer to get and kick the mumps when we're young is that we build up a natural active immunity to the virus that causes it, and then we don't have a recurrence when we're an adult. If you get your initial occurrence of mumps infection as an adult, it can lead to conditions such as sterility. Okay. Now the act of swallowing is detailed here, so let's take a listen.
Swallowing, or deglutition, is the process by which food passes from the mouth to the stomach. This movement is controlled by the nervous system and involves both voluntary and involuntary muscle contractions. Before food is swallowed, it is mechanically broken down in the mouth by chewing or mastication. The salivary glands secrete the enzymes lingual lipase and salivary amylase. Salivary amylase begins the chemical breakdown of starch, carbohydrates, in the mouth. The water content of saliva helps bind particles together to form a bolus that can be swallowed. Swallowing occurs in 3 stages. The first is a voluntary phase called the buccal or oral transit phase. Here the tongue moves upwards and backwards against the hard and soft palates to push the bolus into the oropharynx. Next is the pharyngeal stage. in which involuntary movements push the bolus through the pharynx and into the esophagus. Movement of the bolus stimulates receptors in the oropharynx, which send impulses to the deglutition center in the medulla oblongata and the lower pons of the brainstem. The brain signals the soft palate and uvula to close off the nasopharynx, and the epiglottis to seal off the larynx. This prevents the bolus from entering the respiratory tract. The upper esophageal sphincter relaxes to allow the bolus to move into the esophagus and contracts to reduce backflow into the pharynx. In the final esophageal stage, the bolus is pushed onward by peristalsis, a progression of involuntary wave-like contractions of the circular and longitudinal smooth muscles of the esophagus. As the bolus approaches the end of the esophagus, the lower esophageal sphincter relaxes and the bolus moves into the stomach. So, in summary, food moves from the mouth, through the oropharynx and esophagus, and then into the stomach.
So the stomach lies just beneath the end of the esophagus. The doorway into the stomach is called the cardiac sphincter, and it is a smooth muscle ring that opens up to allow the food to drop into the stomach from the esophagus. The stomach has several parts: the domed upper fundus, the main portion, which is the body, and then the pylorus. Ridges that line the stomach, known as rugae, allow the stomach to stretch when it fills with food, and it produces secretions such as an alkaline mucus, hydrochloric acid, an enzyme called pepsin, and a hormone called gastrin. Okay, the hydrochloric acid produced by the stomach is twofold purpose. One is to sterilize the food that drops into it from the esophagus, and the other is to promote chemical breakdown of all of the macronutrients. In addition, we have pepsin, which starts the process of protein breakdown. The enzyme pepsin recognizes particular amino acid sequences in the protein that we eat and cleaves them, and the result is smaller polypeptide chains that will eventually be broken all the way down into amino acids once we finish moving through the duodenum and the jejunum. Okay, the gastric hormone gastrin is a chemical signal that promotes the production of gastric juice itself. So this is a hormone that actually acts on the organ that produces it. An intrinsic factor is a molecule that allows us to absorb vitamin B12 across the gastric lining into the blood supply, and this is critical for the production of red blood cells. If we lack intrinsic factor, or if we have a damaged gastric lining, then we can end up with a condition known as pernicious anemia, in which we have insufficient B12 to produce DNA, which is critical for generating the stem cells that produce red blood cells. Some stuff absorbs across the stomach lining in addition to B12. A lot of hydrophobic substances can go straight into the blood, such as alcohol and certain drugs. Okay, limited substances can also be digested here, the primary one being protein, but you do get some hydrolysis of lipids and of carbohydrates as well. We should note that the regulation of the action of the stomach is both hormonally and autonomically controlled. The main parasympathetic lead to the stomach is the vagus nerve, cranial nerve 10, and that promotes an increase in churning in the stomach as well as an increase in the secretion of gastric juice. You can see the parts of the stomach here. The exit out of the stomach, the lower esophageal sphincter or pyloric sphincter, empties into the duodenum. The lesser curvature is on the top part of the stomach, and the greater is on the under part. The lesser curvature is attached by the lesser omentum, which is connective tissue that latches as part of the stomach to the underside of the liver, while the greater curvature has dangling from it the greater omentum, which is basically connective tissue that stores lots of fat, as well as blood vessels and nerves and lymphatics, and pads and protects a lot of the lower digestive. The rugae are designed to allow the stomach to stretch when it fills with food. And again, one of the unrecognized roles of the stomach is to allow us to do something known as discontinuous feeding, in which we can eat a meal, stop, and then carry on our lives. If we had no stomach, we couldn't do that. We'd have to be eating constantly in order to survive. The act of gastroscopy is essentially a way to look inside the stomach for problems related to digestion. An example would be a gastric ulcer. This is a bleeding sore in the stomach lining that can be caused by infection from things like Helicobacter pylori. The danger, of course, is that the bleeding sore can be exacerbated by the acid production in the stomach, and that can result in a perforated ulcer and the leakage of gastric juice into the abdominal pelvic cavity, producing an immediate medical emergency because you begin breaking down the components of your abdominal pelvic cavity. We talked earlier about the smooth muscle layers in the stomach. Longitudinal, oblique, and circular are going to mix and mash the bolus into chyme, which is a liquid that will be squirted in tiny bursts into the duodenum through the pyloric sphincter. This, again, is important because not only does it continue the process of mechanical digestion, but it aids chemical digestion by increasing the surface area of the food that you eat. The oblique layer, in this case, is the innermost layer of the stomach. Okay? The mucosa of the stomach is made up of deep crypts. These gastric glands contain parietal and chief cells. The parietal cells produce the hydrochloric acid and the intrinsic factor, while the chief cells produce the digestive enzyme pepsin. And there are also enteroendocrine cells that produce gastrin, and that's the hormone that controls the stomach secretion itself. And of course, mucus cells, which protect the stomach from its own corrosive secretion. So the stomach is really the only place that's designed to produce acid and essentially it is able to contain it. Okay, alkaline mucus protects the lining from the stomach acid. In addition to the fact that the rate at which the wall of the stomach is dissolved is slower than the rate at which the wall of the stomach is regenerated, and so the stomach does in fact break itself down, but it builds itself up quicker than it tears itself apart. So that's very important. So those cells are constantly being made deep in the gastric glands, and then they migrate up to the surface, and then eventually, when they lose their function, they get shed. Okay. Now, the conditions that can affect the stomach, we've talked about gastric ulcer already. We treat with antibiotics. A hiatal hernia is where the fundus of the stomach can pop through an opening in the diaphragm called the hiatus, and the diaphragm can close around that part of the stomach and choke off the blood supply, and the result is that part of the organ can die. Okay, the hiatal hernia symptoms are worsened with large meals because of the pressure that the stomach will exert on the diaphragm. The treatment is frequent or small meals, and then surgical intervention if deemed necessary. The use of tools to visualize the inside of the stomach is important in order for surgery to be effective. A nasogastric tube runs from the nasal cavity all the way into the stomach, while a gastroscopy tube or G-tube is implanted directly into the stomach itself. But they're both ways to, again, look at and then operate on the stomach from the inside out. A gastric resection is where we take part of the stomach and remove it. This is a common task in conditions such as stomach stapling. Sometimes we do what's called a lap band in order to reduce the volume of the stomach and cut down on the size of your meals in individuals that are morbidly obese. Pyloric stenosis is just an overly narrowed out overflow of the stomach that can result in conditions such as emesis. Okay, and of course, another complication of that is that the stomach acid can erode and scar the esophagus and the pharynx, as well as erode the enamel on the teeth. Vagolytic effects basically are a method of slowing the gut's motility and its secretions in order to quit exacerbating some of these symptoms. The next portion of the digestive system is the small intestine, which is designed primarily for nutrient absorption and the propulsion of the remaining waste material towards the colon. The main parts are the very short duodenum, which comes right off of the pyloric sphincter, which leads into the jejunum, where we do most of the absorbing of nutrients, and that leads into the ileum, where primarily waste products make their way to the ileocecal valve, at which point the waste products are going to enter the cecum. Okay? The function of the small intestine is basically propulsion of the food material through the tube and absorption of the nutrients. There are also hormones that coordinate these activities that we'll talk about as well. The surface area of the small intestine is quite extensive, and that's to maximize available space for the pickup of nutrients and loading them either into the blood or into the lymphatic system. The villi have in their core capillaries, which eventually drain into the hepatic portal vein in the back of the liver, and lacteals, which are eventually going to drain into the thoracic duct, which will eventually drain into the left subclavian vein. And that's where your lipid content goes. And that's because the lipids are too large to get into the capillaries on their own. Okay. The simple columnar epithelial cells that line the villi have on their surface microvilli, which increases the surface area even more. And we also have ridges and grooves in the small intestine called plicae circulares, which increase the surface area even more. And as I'm sure you're aware, the pipe itself is extensively folded in this region. So we get a lot of surface area in a relatively small volume in order to do the job. The large intestine is where the waste products end up. So there's no nutrient value to us for the material that makes it to the large intestine. However, there is nutrient value for these waste products for the bacteria that live there. Examples being E. coli, and they break down our waste products and make important stuff for us like vitamin K and B complex vitamins. The cecum is a pouch that is at the bottom of the ascending colon and is attached to the ileocecal valve. On its underside is the appendix, which is a little blind-ended sac, which was once thought to be essentially a useless appendage, but we now know that it contains immune cells that help to fight pathogens that make it into the colon, as well as bacteria that can repopulate the colon in the event that they get primarily wiped out in the rest of the colon. The colon has several parts. The cecum leads into the ascending, which leads into the transverse, and then the descending and sigmoid colon, which then lead into the rectum and the anus. We should note that in the large intestine, there are little pouch-like swellings that are called haustra that are actually produced by the contraction of the longitudinal smooth muscle in the wall of the intestine, which is called the teniae coli, a very tiny band of longitudinal smooth muscle that pushes the waste material toward its ultimate end. The fact that we don't have extensive smooth muscle in the large intestine reflects its job. Again, you don't need a lot of power in order to move waste products towards the rectum and the anus. Okay, the large intestine also absorbs a lot of water from our waste products. It also allows us to eliminate waste gas, and we also pointed out there are bacteria that live in there that, through their metabolic activities, produce vitamin K and B complex vitamins, which we need. Okay? So this is an example of what we call a symbiotic relationship, in which two living organisms are able to provide benefits in the relationship that promote the relationship. You can see here the conditions that can affect the large intestine. You can have what are called physical or functional blocks in the large intestine that result in the passage of waste material stopping at that point, and that results in a massive expansion of the colon upstream of that region. The risk, of course, is that it could rupture, and that would produce bacterial infection of the peritoneum, causing peritonitis, and then the bacteria can move into the blood, and we call that septicemia. And if we don't treat, that can result in death. Okay, functional block is where the neurons that promote the peristalsis quit working, and so the pushing of the waste material stops at that point. And then in a physical block, what we have is a mass that blocks the food. Could be a tumor, could be indigestible material. There are cases on record of people eating clay and hair, and that basically doesn't get digested. What we do about it is that we resect that part of the colon that's not working, and then as a temporary measure, we can do a colostomy where we hook up a bag to the functioning part of the colon, and the waste material flows into the bag, and then we swap the bag out. And then the back half of that is that we can attach the functioning part of the colon to the remaining pipe if there's enough to get to the rectum and the anus, and we can restore flow. Okay. Another condition that can affect the large intestine is Crohn's disease, in which you get an inflammation of the walls of the large intestine. These can result in pouch-like structures called diverticula erupting from the wall, and they can get plugged with waste material and can produce a condition very similar to appendicitis, in which the appendix can get plugged with waste material, swell, and rupture. Okay, and so the treatment there is usually surgery. Hemorrhoids are simply varicose veins of the anal canal that are uncomfortable and they itch. They can sometimes block passage of waste material, but their main risk is that they serve as a source of infection, because if they bleed, the bacteria in the area can easily move into the blood and produce sepsis. So the people to see for that are your proctologist or your GP, okay? And they will recommend either surgical or drug treatments in order to deal with those varicose veins, okay? The diagnostic for that is something called occult blood, where we can detect hidden blood in the fecal material, which means you've got a bleed somewhere. An enema is simply a way of introducing liquid into the colon in order to promote the passage of occluded waste material. Okay, so sometimes people that are severely constipated end up requiring an enema in order to restore flow. The problem with the large intestine as we get older is that the movement of waste material through the pipe slows, and that causes it to tend towards constipation as we absorb too much water out of the waste material, and it's unable to move through that portion of the pipe very effectively. In the event that the material moves through too quickly, we end up with a condition called diarrhea, and that causes us to lose water and electrolytes and can put us at risk for dehydration. This is just a look at the accessory digestive organs.
The salivary glands, liver, and pancreas produce secretions that are discharged into the lumen of the GI tract. Click any of the buttons to study the accessory glands. The salivary glands produce saliva that moistens ingested food and cleanses and protects the mouth. The major digestive function of the liver is production of bile. It is produced continuously by hepatocytes and is stored and concentrated in the gallbladder. Bile is necessary for the digestion and absorption of fat. The exocrine pancreas produces digestive juice that contains enzymes to digest all major foodstuffs. It also produces bicarbonate to neutralize acidic chyme from the stomach.
is an important as well as structurally and functionally complex organ. One of the important functions of the liver is to receive and take up nutrients and other molecules absorbed from the intestines before the blood is returned to the heart via the inferior vena cava. The liver has dual blood supplies, one venous and one arterial. The portal vein, which carries blood from the spleen, pancreas, and intestines, contributes about 75% of the blood volume to the liver. This blood is rich in nutrients and other absorbed molecules, but relatively poor in oxygen content. The hepatic artery, a branch of the celiac trunk from the abdominal aorta, contributes about 25% of blood volume entering the liver. This blood is well oxygenated, but nutrient poor. Blood from the portal vein and hepatic artery mixes as it enters and passes through a liver lobule, the classical structural unit of the liver. Blood then percolates through the lobule and is collected by the hepatic or central vein. Central veins unite to form larger sublobular veins, which ultimately join the hepatic veins. Blood flows to the heart via the inferior vena cava. Bile comprises the exocrine secretory product of the liver. It is stored in the gallbladder. During digestion, bile is released from the gallbladder through the cystic duct into the duodenum to aid in the digestion of fats. The filtration of blood and the production of bile takes place within the structural and functional unit of the liver, the lobule, where the terminal branches of the vessels carrying incoming and outgoing blood meet. The liver lobule is roughly hexagonal in cross-section. In the center of the lobule lies the central vein, which collects blood from the lobule and carries it to the hepatic veins. Located at the lobule periphery are branches of the vessels supplying incoming blood, the portal vein and the hepatic artery. Also located here is the bile duct. Collectively, the portal vein, hepatic artery, and the bile duct together comprise the portal triad. Taking a horizontal cross-section of the lobule gives us an arrangement typically seen in histological preparations. In this view, we can identify the central veins and associated portal triads. There are two prevailing views of liver lobule organization, the classic liver lobule, or anatomical model, and the liver acinus. The classic liver lobule is based on the structure of the lobule we just discussed. It is hexagonal in shape and is defined by portal triads surrounding a single central vein. To identify a lobule in a histological slide, first find a central vein. Next, locate the portal triad surrounding that vein, usually about 6 at the corners of the hexagonal prism. An imaginary line connecting the triads represents the outside border of the lobule. In the classic liver lobule, blood flows from the portal triads toward the central vein. Bile flows in the opposite direction, from the central position toward the portal triads at the lobule periphery. Remember, the classic liver lobule model emphasizes the anatomical structure of the lobule. The liver acinus is another way to view liver structure. This model is important for understanding liver physiology and pathology. The structure of the acinus overlaps two classic liver lobules. The acinus is diamond or oval shaped. It involves approximately 2 portal triads and 2 central veins. To identify the acinus, find 2 adjacent portal triads. This makes the short axis. Next, find the closest central vein on either side of the triads. This is the long axis. The resulting shape is a diamond or oval. Blood still flows from the portal triad to the central vein, but within the shape of the acinus, the flow is from the center to the periphery. Bile flows in the opposite direction, from the periphery towards the center. The acinus model is important because it emphasizes the metabolic differences in hepatocytes between the portal triads and the central vein. The cells in the acinus are divided into 3 zones and are numbered in the direction of blood flow, from 1 to 3. Cells in zone 1 lie along the short axis, between the portal triads. Thus, these cells are first to receive everything in blood, including oxygen, absorbed nutrients, and absorbed xenobiotics. Cells in zone 2 have characteristics intermediate between the cells of zones 1 and 3. Cells in zone 3 are closest to the central vein, and therefore are the last to receive incoming blood. As blood moves towards the central vein, it becomes depleted of oxygen, nutrients, and xenobiotics. To review, the liver lobule is the anatomical model. It is hexagonal in shape. It involves 1 anatomical liver lobule, and blood flows from the periphery to the center. The liver acinus focuses on function. It is diamond or oval shaped. It involves two adjacent anatomical liver lobules. The blood flows from the middle, which we discussed as a short axis, to the periphery.
Okay, some clinical conditions to be concerned about that can affect the digestive system include jaundice, which is a yellowing of the skin and the sclera due to a buildup of bilirubin. This can occur when gallstones can block portions of the drainage out of the liver, such as get lodged in the cystic duct or in the bile duct. And this condition is called choledolethiasis. And we can treat it with lithotripsy, which is sound waves to crack the stones, or sometimes surgery. Bleeding, of course, can happen anywhere in the digestive tract. A bleeding tumor detected by occult blood or frank blood could be an indication of stomach cancer or cancer in the small or the large intestine. Okay, or occult blood could be an indication of something as mundane as a hemorrhoid. Okay. One of the things that also occurs when the liver is compromised is loss of liver function. If you lose complete liver function, you die because the liver does too many things to sustain us that we have no artificial replacement for. Some of the jobs of the liver include adjusting the fuel content of the blood by creating glycogen and adipose tissue that serves as the body's pantry when we need nutrients between meals. It detoxifies the blood. It also removes pathogens from the blood. It creates bile. It makes clotting factors. And none of this can be replaced if the liver goes down. Fortunately, the liver is unique in that it has regenerative power. You can lose up to 80% of your liver and it'll grow back. In addition to the fact that it has a condition known as immune privilege, where you need a replacement liver or liver lobe. You don't need a perfect tissue match. You only need to match the blood type. Okay? One of the complications of scars on the liver that can result from a condition known as cirrhosis, where we abuse the liver because we imbibe too much alcohol. Esophageal varices are bulging blood vessels in the esophagus that can bleed and block the esophagus and also increase the risk of infection and as well as blocking food from getting into the stomach. And then another condition is ascites, in which the liver makes insufficient albumin, and the result is that the blood loses via osmosis water to the surrounding tissue. This is pronounced in the abdomen, which becomes distended. Okay, and we can treat this by draining the liquid off and hopefully repairing the organ. Okay, pancreatitis is just an inflammation of the pancreas. Cystitis is an inflammation of the gallbladder. Both of these can be caused by gallstones. Okay, so a gallstone is simply crystallized bile that can block the cystic duct, or can block the bile duct, or can block the hepatopancreatic ampulla. If it does so, it could lead to rupture of the gallbladder, and that will increase the risk of infection. Or it could lead to destruction or inflammation of the pancreas because we're not able to drain the pancreatic juice into the small intestine with the gallstone in the way. So we can treat with surgery or with lithotripsy. If the pancreas is destroyed, it's usually as a result either of pancreatic cancer, which can originate in the organ and spread without symptoms for quite some period of time, and that's one of the reasons that it's often a lethal diagnosis. Or it can be the result of proteolytic enzymes auto-activating within the pancreatic duct and digesting the organ away. Okay, most proteases are produced in an inactive form in the digestive system, and they don't turn on until they hit the lumen of the tract, at which point they begin their work on the macronutrients. And if they sit too long in the pancreatic duct, they can turn on of their own accord and destroy the organ that hosts them. Okay. Next thing we want to talk about is where all of these absorbed components go. So We talked earlier about the fact that polysaccharides, which you get primarily from your vegetables and your fruits in your diet, have to be broken down into monosaccharides in order to absorb into the blood. So salivary amylase begins this process in the oral cavity by breaking down starch into shorter stretches of glucose molecules, and then pancreatic amylase continues the process, and then there are disaccharases which complete the process of production of monosaccharides, and then they're absorbed into the blood by a combination of active and passive transport. Monosaccharides end up being absorbed by the villi, going into the capillaries in the villi, and that is going to drain eventually into the hepatic portal vein, where this will be stored as fat or as glycogen. Okay. Sometimes, if we lack one of the components to break down the carbohydrate in our diet, the carbohydrate will end up making it to the colon and will over-fertilize the bacteria that live there. Okay, basically they'll go nuts because they have a rich food source, and that'll cause gas, distension, and pain. An example of this is lactose intolerance, in which lactase levels are either genetically low in some individuals, or they drop over time. And the lactose, which is a disaccharide that's found primarily in dairy, doesn't get broken down. It ends up making it to the colon, where the bacteria overgrow and cause considerable discomfort to the individual that suffers from it. So we deal with that either by giving you lactase or by having you avoid dairy. Okay. A sugar that we do not chemically break down that's in our diet is cellulose, which we know better as fiber, which passes ultimately into the colon, where the bacteria that live there break it down because they use it as fuel. For us, it has no calorie benefit, and so an excellent way to diet is to eat high fiber foods, because not only do they not contribute to the calorie content, but they also are going to promote the easy passage of stool, because they're osmotically active and tend to draw blood into the stool and make it easier to pass. So this is something that's especially important as we get older and the movement of fecal material through the large part of the pipe slows. We need more fiber in our diet. So it's a good idea to get into this habit as early as possible. Gastric hydrochloric acid is there to sterilize the food that we eat, but it also produces an environment in which inactive pepsinogen is converted to pepsin and can promote the breakdown of protein. Okay. Other proteases are produced by the pancreas, and they include trypsinogen, chymotrypsinogen, carboxypeptidase. Most of these are produced as inactive zymogens initially, and it's when they hit the lumen of the digestive system that they become activated and begin to attack the protein. And again, this is just to preserve the integrity of the organ or the tissue that makes them to begin with. Okay. Enterokinase is an enzyme that's produced in the duodenum, and again, its purpose is to shuttle phosphate groups during the digestive process. Okay. Fats are a different story. Okay. Fat breakdown enzymatically is accomplished by lipase, lingual lipase in the oral cavity and pancreatic lipase in the small intestine. But because lipids do not dissolve in water, they require a mechanical process called emulsification, in which the detergent action of bile salts causes fat droplets to disperse so that their surface area is maximized, and that allows the lipases an easier task of breaking down the fat that's in the diet, and that makes it easier to shuttle those breakdown products ultimately into the lymphatic system, and from there we can end up porting it into the blood, where the thoracic duct meets the subclavian vein. Okay. So it's really a two-stage process involving both the emulsification and the enzyme breakdown. If you're missing one or the other, then you're going to have a hard time dealing with the fat in your diet. That's one of the reasons why sometimes when people have their gallbladders removed, it's recommended that they restrict the fat content of their diet. Okay? So you can see here the movement of food through the pipe. I sometimes like to play a game with my students called I Am a Twinkie. So where does everything happen and where does it go? So we can start in the mouth. You begin by putting the Twinkie into your mouth and you chew it with your teeth. And that's mechanical breakdown. And that moist food mass will get compressed into a bolus by the tongue and the action of the teeth and the gums and the hard and the soft palate. And then you'll swallow. When the soft palate blocks the nasopharynx and the epiglottis blocks the trachea, the food can pass into the oropharynx, the laryngopharynx, and down into the esophagus. Okay, no chemical or mechanical, well, some mechanical breakdown, but no chemical breakdown is happening here. The food eventually makes its way to the cardiac sphincter, where it passes into the stomach. The hydrochloric acid in the stomach helps to sterilize the food that we've eaten, and the pepsin helps to promote or initiate the breakdown of protein. Absorption here is minimal. It's limited to hydrophobic compounds like alcohol and vitamin B12 through the action of intrinsic factor. And then the bolus gets liquefied by the churning action of the stomach combined with the enzymatic action. It's already there. And then it gets squirted into the duodenum through the pyloric sphincter, at which point both the gallbladder and pancreas discharge into the bile duct. The pancreatic juice contains bicarbonate, which neutralizes the acid from the stomach so that we don't carve a hole in the duodenum, causing a duodenal ulcer. And then it also contains enzymes that break down fat and carbohydrate and protein. Okay? The bile is primarily to emulsify the fat, and it makes it easier for the pancreatic lipase to finish its job. And then brush border enzymes finish the job of producing monosaccharides and amino acids, which get loaded into the capillaries, which eventually are going to drain into the hepatic portal vein of the liver, okay? While the lipases break down the triglycerides into fatty acids and glycerol. Micelles, which are little fat droplets, are then going to be moved into the lacteals, and then those lacteals will take that fatty lymph called chyle, empty it into a structure called the cisterna chyli, which leads into the thoracic duct, and the thoracic duct will pipe that stuff up to the subclavian vein. In the meantime, the material moves from the duodenum to the jejunum to the ileum, and through the ileocecal valve into the cecum, from there into the ascending, then transverse and descending colon, and then out the rectum and the anus. And that's the entire trip. Okay. Important that you understand the 5 categories of nutrients and what they do. You don't want deficiencies in any. You want a balanced diet. Okay. Remember that we are omnivores, so we need to eat a little bit of everything. Simple sugars are important as fuel sources and also as structural components for DNA and RNA and molecules such as glycolipids and glycoproteins. They come from complex carbohydrates, and they also come from the direct ingestion of monosaccharides. You don't want too much of this. A high glycemic index will result in the production of excess body fat, and that causes obesity. Right? Proteins are basically eaten to make new protein. Okay? They're not synthesized by the body, and they're not stored by the body in a storage form. They're stored by the body in the sense that we're made of protein. So you eat protein to make protein. Complete protein comes from eating what we are, which is meat, whereas incomplete protein comes from limited vegetable and fruit sources. And so when you're going with a strictly vegetarian diet, one of the things you want to do is to make sure that you mix and match classes of vegetable material, vegetable nutrition, so that you get complete protein. An example, if you were to eat only legumes, beans and peas, you would lack certain amino acids, whereas if you were to eat only grains, you would lack the complementary amino acids. And so a complete protein meal would be something like red beans and rice. If you eat incomplete protein, then you're not going to have the building blocks necessary to build the body, and the result is going to be deficiencies in function in tissues and organs. Fats are the calorie champ in our diet. They come in different forms. There are unsaturated fats which have double bonds in their fatty acid chains, and as a result are liquids at room temperature and have fewer calories, and so they're more heart healthy for you. And then there are saturated fats, which are solids at room temperature. Examples would be things like Crisco, and those are less heart healthy for you. They have tons of calorie in them. They're primarily consumed for their energy value, okay, because of their high calorie content. And they are also functional components of cell membranes and things like myelin, okay, and membranous organelles. Essential fatty acids are ones that we have to eat in order to have. We can't synthesize these in the body from other components. Examples include linoleic acid, which contains double bonds, is an important component of cell membranes. Infants, note, should not be placed on a fat-free diet because their central nervous systems require raw material for myelination to take place. Very important. The amount of saturated fat should always be limited, again, because of the potential for excess calories, as well as the production of plaque on the arteries, which can contribute to conditions like atherosclerosis and arteriosclerosis. Vitamins are just tools that are used by enzymes in order to carry out their chemical activity, okay? The fat-soluble vitamins are A, D, E, and K, and can be stored in the body in amounts that can become excessive and toxic, okay? Whereas the water-soluble vitamins are the B complex and the C vitamins. They're not stored by the body, and they're basically passed out in the urine if you megadose on them, okay? Vitamin K is critical for things like blood clotting, okay? Vitamin A is critical for the production of photopigments in the retina of the eye. Vitamin D is critical for the mineralization of bone, and vitamin E is important for the destruction of free radicals, which are molecules that can wreck other molecules by stealing electrons from their chemical bonds. Okay? But be advised that you can overdose on these. All right? Just like any fat-soluble substance, we have a lot of fat in the body, which means we have a lot of potential fat storage in the body, and that can lead to complications if we overuse it. Minerals are also tools that are used by enzymes to carry out their jobs, as well as being critical in determining membrane potential, and also the movement of water in the body. Okay? So these are inorganic substances. Some important minerals: sodium, potassium, chloride, calcium, phosphorus, magnesium, iron, iodine, manganese, molybdenum, okay? All critical, okay? A deficiency of iron can cause anemia. An excess can cause hemochromatosis. Iodine deficiency can produce goiter, hypothyroidism, and cretinism. Hypokalemia and hyperkalemia can cause fatal heart dysrhythmias, and sodium imbalance can cause water imbalance. Sodium deficiency causes low blood volume and shock, and too much sodium expands blood volume and can promote heart failure. Okay? There's a table in your book 23.3 that gives you some examples of improper ingestion and use of minerals. Okay? A balanced diet contains all essential nutrients and includes a variety of foods. A lot of health problems are thought to originate as a result of poor dietary choices. And in this country, there's no reason for anyone to starve, and really no reason for anyone to not be able to eat a healthy diet, because we do have an abundant amount of low-cost food. In other countries, not so much, okay? This is why the United States is known as the breadbasket of the world, because the grain production in the Midwest alone feeds over a third of the world's population. And when you think about that, that's a pretty small plot of land that does a pretty big job. Okay, how is it that we control how much we eat? Well, there's conscious control. Sometimes that ends up failing us, though. And there are hormones and nervous components that control this as well. Examples of hormones that are suspected to control feeding include leptin and orexins. Okay, the hypothalamus contains our feeding center as well as a lot of our other primitive drives, so it's critical for our survival. It also contains our satiety center. So there are different theories as to why we eat or don't eat. The glucostat hypothesis says that glucose sends inhibitory information to the feeding center, while the lipostat hypothesis states that fat cells secrete leptin, and that's an appetite suppressant. And that's great. That absolutely is true for animals. Okay? There's no doubt that in animal models we have cured obesity and starvation many, many times. But humans eat for other reasons. Okay? Humans eat for emotional reasons in addition to eating in order to satisfy hunger and nutrient and energy needs. And so frequently a drug that targets feeding behaviors in animals can be ineffective in humans because of this other factor that controls why we eat. Okay, so at the end of the day, really, if we were to follow one simple rule, which is to eat when we're hungry, we would avoid a lot of these problems of malnourishment or of obesity. Unfortunately, it can be very difficult for humans to do that. Okay. Energy is critical. All right. Without energy, we die, and the energy is in the chemical bonds of the food that we eat. Our energy expenditure depends on our activity level as well as our genetics. So, essentially, if you eat more calories than you burn, you're going to gain weight, bad weight in the form of body fat, right? And if you burn more calories than you eat, you will maintain usually a healthy body weight if you're doing that within reasonable parameters. Okay, if you're trying to starve yourself, of course, you're going to get into major trouble. Okay, so the bottom line is that a balanced diet and moderate exercise should be enough to keep you healthy most of your life. So when we're talking about exercise, we're talking about really two kinds of exertion. There's aerobic exercise and resistance exercise. In aerobic exercise, we're talking about getting your heart rate up in order for you to improve your cardiovascular health by increasing the amount of blood delivered to cells and tissues, and also by taking some of the load off of the heart. In resistance exercise, what we're doing is we're increasing muscle mass by moving the load. Okay, and so a balanced exercise program usually does both in order to get the body to optimal health. Okay, so an example of aerobic exercise might be something like jogging or playing basketball, whereas resistance exercise would be stuff like lifting weights. Okay, so most of this you can do in your own home. Okay, you can do simple resistance exercise by working against your own body weight, and those would be things like sit-ups and push-ups, planks, dips. Okay, you can look up what those are. They don't require hardly any equipment. And then for aerobic exercise, you can do something as simple as jumping jacks, or if you have steps in your home, you can use your steps. If you have a dog or a cat, you can walk the dog. The cat, maybe you can play with the cat. You can go play basketball or tennis or squash, something to get your heart rate up. You can pedal a bicycle if you want, okay? But it's the balance of these activities that'll determine your overall health. You don't want to overload on one or the other, okay? So with that, we draw to a close this particular podcast. Again, if you have questions, by all means get in touch with me through email. I should get back to you within the day, and I will join everybody in the next podcast. I appreciate you listening. Thank you.